For me, the most challenging one is the fungal infection in the immunocompetent host. So preventive strategies to avoid invasive candidiasis. So these are my disclosures, none of them actually relevant for this presentation. Why is it important? The next speaker will talk on the treatment of the disease, and he surely will stress its clinical importance. It has a high mortality, more than 50% in many studies, and a very costly disease as well. And on top of it, it's quite difficult to diagnose. It doesn't have a typical clinical picture. It's often, well, an incidental finding, meaning that the blood cultures come back positive, rather than the clinical picture is something that you'd recognize without any other tools available. On top of this, we have very limited tools to diagnose it. And, well, culturing is probably the most often used technique, which is often delayed because it takes time, and therefore also the treatment, adequate treatment, is late. And this is why there's quite some interest in preventing the disease, because there also appears to be a window of opportunity. And this is a nice figure showing you the cumulative incidence of invasive candidiasis in critically ill patients. And you can see that actually the majority of the cases, the black bars are actually the proven cases. The majority occurs not within the first 5 to 6 days of ICU admission. It's a disease that typically that takes some time to develop and occurs after prolonged exposure to the ICU environment. So apparently there is some room, some time in which we can do something in order to prevent the infection from happening. And there is also some physiological rationale for this. Of course, Candida doesn't come out of the blue. It's colonizing the patients often, and it takes some time to go from colonization, here on top of this slide, to invasive disease. And so there's different steps, and if we can somehow prevent this first step from happening, maybe we can avoid the invasive disease after all. Now, there is a lot of confusion and misconceptions around the different terms that are being used. Prophylaxis and the other strategies. And this ASCMID guidelines, although it dates back from 2012 already, it does offer some good guidance on using the correct words. So based on the probability of infections, there are different strategies. Prophylaxis is the most easy one. We use prophylactic antibiotics. It means, or prophylactic antifungals, it means you use a drug in a patient who doesn't have any sign of infection, but because of some reason is at increased risk. A preemptive therapy can be given in patients in whom you have a diagnosis-driven treatment without proof of infection, but there's some microbiological clue, like the use of beta-D-glucan, suggests that indeed Candida is present and may be an issue. Empirical therapy, on the other hand, is the situation where there's clinical information pointing to infection, most often fever, although of course it has a lot of limitations, but you don't have any evidence yet, or evidence at all, of invasive infection. It's just the setting where you would expect that Candida is maybe causing the infection. And at the other end of the spectrum, there's directed therapy. In these situations, you have confirmed invasive infection. And that's the easy thing. Well, I'm not saying it's easy, and the next speaker will cover it. But in terms of diagnosis and the certainty of treatment, that's easy. But the other three indications or strategies are often lumped together. And I think it's very important to discriminate prophylaxis from preemptive and empirical therapy. And this has been studied in a number of papers, which I will review in a few minutes. One of the first papers reporting on the prophylactic use of fluconazole is this paper, already almost 20 years old, looking at patients with recurrent gastrointestinal surgery because of leakage. It was a randomized controlled trial. 400 milligrams of fluconazole versus placebo. Mind you, very small randomized controlled trial. I mean, these times, of course, we would expect at least 3 figures and not have 23 and 20 patients in this study. Nevertheless, as you can see, there was a reduction in the number of patients developing Candida peritonitis and a trend towards Candida infections overall. And this really sparked the interest, and I think a lot of us are still using prophylaxis in this specific patient group based on this study. And as you can see here, the typical time frame, not an infection that develops in the first few days, but after probably 1 week of admission, and in this case, it was better with fluconazole. And there's been quite a number of studies after that, and I'm not going to review one by one. I'm just citing from this Cochrane review that was published last year and reviewed all the evidence. And this is the summary table, and I'll walk you through it. And as you can see on the top of the table, all-cause mortality indeed was not affected. You can see the relative risk, 0.93, but the confidence interval was quite wide. It did include 1, and so no clear effect on mortality with a moderate quality of evidence. Some of the studies also looked at proven invasive fungal infection, and this is where it gets interesting. Indeed, the relative risk is 0.57, so almost the risk is halved when using antifungals based on 17 trials, although the level of evidence of these studies, this specific subset of studies, was low. So let's have a closer look at the evidence table. It's quite busy, and of course I want you to look at the diamond shapes. You can see that the fluconazole is on top, and indeed the largest number of studies have been looking at fluconazole, and only a few studies have been looking at the newer drugs available, caspofungin and micafungin, and you can see indeed that the advantage, the trend was the largest in the fluconazole. This was the endpoint mortality, and as I've mentioned, there was no effect. This is the data reporting on the endpoint fungal infection. Again, the largest number of studies looking at fluconazole on top, and here the effect was indeed statistically significant with a reduced rate of invasive fungal infection in patients treated with fluconazole. Caspofungin, 1 study only, and micafungin, 2 studies, but no effect here. So clearly, maybe we were able to reduce the number of infections, but apparently it doesn't seem to affect mortality. Let's go back to the risk factors and let's analyze why these effects were, why this was found. There's quite an extensive number of risk factors for invasive candidiasis. It's the usual suspects, of course. Antibiotic exposure is an important one, the presence of catheters, parenteral nutrition, and disease severity, and, well, length of stay and the duration of the exposure to the ICU is an obvious other one. And this is also superseded by the effect of Candida colonization, because, as I showed you, this is the first step before you get invasive disease. And of course, a lot has changed in terms of understanding these risk factors, and over time we've become better at using our antibiotics and reducing antibiotic exposure. We've been using less parenteral nutrition. So over time, when these studies were done, again, I've shown you studies that are 20 years old, I think we've been handling these risk factors differently, and maybe what we found in the past is no longer relevant to today. And indeed, when we look at the baseline risk, this is really very important when you want to study the effect of an intervention. And this is a nice analysis that was done. Although it's already 10 years old, it still holds a lot of value today. And these investigators looked at different patient categories based on the estimated risk, as you can see here on the left. And they calculated the number needed to treat to prevent one episode of invasive fungal infection. So you can see, for instance, at the top of the table, if you have a very low risk of invasive fungal infection, right, lower than 1%, then you would need almost 200 patients you need to treat 200 patients before you can avoid one invasive fungal infection. And this is not going to be very effective. And logically, the lowest number needed to treat was found in the highest risk category. So it's all about identifying the patient who is at the highest risk of developing an invasive fungal infection and target the intervention to these patients. So this is why there's been a lot of literature looking at ways to better predict invasive candidiasis. And I'll review some of them with you. The oldest one is probably the Colonization Index. This was developed by Swiss investigators. And the index stands for the number of positive sites colonized with Candida in a patient over the total number of sites that were sampled in a patient. Later it was amended and the corrected colonization index was developed, meaning the number of heavily colonized sites over the number of the total number of sites. And this was actually first studied in a, well, relatively small group of high-risk patients, 29 patients out of 650. So it's quite old literature, and you can see here a small amount of patients. Each dot is an individual patient, and apparently there's indeed some signal. The higher this index is, meaning the more sites are positive, the higher the risk of invasive infection is. Whereas this logical, let's see in a minute whether this holds true in the studies that have been done. Another approach was taken by these investigators from Spain. They looked at more than 1,600 ICU patients who stayed in the ICU for 7 days or longer. And of these 1,600 patients, about 100 developed invasive candidiasis. And they looked for factors that were associated with this invasive candidiasis. Of course, there's some selection bias here. So they only looked at patients who had been in the ICU for 7 days or longer. And it's not so easy to predict this, of course, at the very start. I'll come back in a minute why this may be important. And you can see, indeed, these are the factors were associated with parenteral nutrition, severe sepsis, surgery, and Candida colonization. Essentially the known risk factors from other studies. This is the performance of this Candida score, and you can see, indeed, the area under the curve looks quite nice. Not so high positive predictive value, but negative predictive value quite good at ruling out invasive candidiasis. But the question is, of course, is this a good score to use to identify patients who are really at risk? And I'll show you the data in a minute. Before, I'd like to show you the clinical prediction rule that was developed by Dr. Ostrowski-Zeichner. It's a more complex score, as you can see. So either the use of antibiotics or the presence of a catheter. I think these two factors are quite common in our ICUs, right? Plus two or more of these different variables. And again, you see the surgery, the parenteral nutrition, and RRT coming back here. And they found, indeed, similar results, actually a positive predictive value of 9% and a high negative predictive value. Mind you that indeed this rule identified only 1 out of 3 infections, 1 out of 3 invasive candidiasis infections, and an overall quite low incidence of invasive candidiasis. Yeah. That's why it was slightly changed. This is the 2.0 version of this score, in which mechanical ventilation was added and only one of the additional factors was used. Also, you needed all 3 of the above factors, and it's slightly improved, although indeed now with this score only half of the patients with invasive candidiasis in this cohort were predicted. So we're still lacking actually a good tool to effectively identify patients at risk. And this is a summary of the different strategies or scores or rules that have been identified. This is an interesting column here. This is the percentage of invasive candidiasis episodes that was identified using this score. As you can see, it's far from 100%. Also, a lot of selection bias, and a lot of investigators only looked at patients who stayed in the ICU for a longer period of time. The problem is that we will be using these scores in patients who are admitted to the ICU maybe for 1 or 2 days. So the risk may be different in this selected group of patients. One of the studies looking or confirming this problem is this study that looked at the external validity of these different rules in another cohort. And apparently, when you change the cohort, for instance, the positive predictive value is much lower. And look at the area under the curves reported here. It's quite lower compared to the original studies. So many of these studies, many of these scores have been developed in highly selected cohorts with limited external validity. So what about the new drugs? What about the echinocandins? A number of studies looked at prophylactic and preemptive strategies, such as this study, randomized controlled trial comparing caspofungin versus placebo in 200 patients, only 5% of which developed invasive candidiasis. Remember, in the table I showed you at the beginning, you needed a 15 or 20% baseline risk to have the highest, to have the lowest number needed to treat. So apparently in these more recent studies, the incidence of invasive candidiasis is lower than in the previous study. None of the endpoints, as you can see in the table at the bottom, was positive. So the use of prophylactic echinocandin, caspofungin in this case, in patients who were identified by the clinical prediction rule, was actually able to show any benefits. Another study specifically looking in patients who underwent abdominal emergency surgery and were admitted to the ICU compared micafungin with placebo, and here again there was no difference in confirmed infection, confirmed invasive candidiasis in this patient. And more recently, a French study, not looking at prophylaxis, but looking at empirical therapy. So this is really the high-risk population. These are the patients that have been in the ICU for quite some time, that are on a ventilator, that have organ dysfunction, that have had exposure to antibiotics, and that develop a new sepsis episode. And you're just in the dark, you don't know what it is, and this is probably where we usually think of invasive candidiasis. These patients were treated either with micafungin or placebo. Survival without invasive fungal infection was the primary endpoint, and no effect on, these are the patient characteristics, as you can see, just confirming the severity of illness, very high SAPS-2 scores, SOFA scores, as you can see here, around 8, a lot of them on norepinephrine, and also about 1 out of 3 on renal replacement therapy. And these are the outcomes in the overall group. No difference in fungal infection-free survival, not in the overall patient population, but also looking at surgical versus medical patients, also looking at patients with a high Candida score, or patients with a high corrected colonization index, or a high beta-D glucan concentration. None of them actually in these different subcategories had a better outcome. There was a difference in, there was a difference though in the fungal infection rate itself, but apparently it didn't impact mortality, and therefore the primary endpoint was not reached. This is a summary of the IDSA guidelines. I'm only summarizing this guideline because the ESCMID guidelines are already dating back from 2012. There's some new evidence that came out, and I think we need to incorporate this in our in the advice. The advice here from the IDSA guidelines is to use fluconazole if you have a high rate of invasive candidiasis. And 5% in your ICU, I think that's quite a lot. A weak recommendation to give an echinocandin, low quality evidence, but they do mention the potential benefit of chlorhexidine bathing because of the study that demonstrated reduced bloodstream infections. So how to use it? What would be my take on this? In unselected ICU patients, I think there's no use of routine prophylaxis. In high-risk patients, yes, fluconazole, but it should be a very high baseline risk, and we've been unable to identify these patients. A preemptive strategy based on, for instance, beta-D-glucan, I think it's an interesting approach, but so far the data are lacking. Empirical therapy, as studied in the French study, apparently does reduce the incidence of infections, but no effect on mortality at all. So it's questionable whether adding an echinocandin or antifungal treatments will really impact the mortality. And a selective strategy focusing mainly on patients after GI surgery and recurrent leak using fluconazole is what we do. And this is essentially my take-home message. It's a very challenging area, and we have particular problems in identifying the patients who would benefit most from prophylaxis. We're really struggling with this. I do think that over time the risk has changed. I've told you about the surgical indication, but any major impact is to be demonstrated. I firmly believe that the different risk factors and the way we've been handling the risk factors does play a role. And all of this really stresses the importance of antifungal stewardship. Stewardship programs have been focusing on antibiotics, and I think it's important, but surely antifungals should be included in this as well. I thank you for your attention.